Hello guys, welcome to a high-yield MCQ video. So let's get started. A one-year-old boy is brought to the pediatric clinic for evaluation of a non-palpable right testis. On examination, the scrotum appears underdeveloped. Ultrasound reveals the testis is located in the inguinal canal. What is the appropriate next step in the management? So observation until 2 years of age, hormonal therapy with HCG, laparoscopic orchiopexy or open inguinal orchiopexy. So these are some cues. So 1-year-old boy, non-palpable right testis, and ultrasound reveals it's in the inguinal canal. So pause here for a bit. Think about what can be the answer, and we'll get started. Okay, so before we get to the answer, let's just delve into the topic a little bit, okay? So cryptorchidism or undescended testis is nothing but incomplete descent of testis, or there's absence of testis in the male scrotum due to arrest at some point in the normal line of descent. So why are we saying it's arrested at some point in the normal line of descent? So that we can differentiate it from ectopic testis, where testicular arrest occurs outside the normal line of descent. Okay, so coming to embryology, let's just quickly go through it. So it's developed from mesodermal genital ridges and testicular descent is the important part, and it's facilitated by gubernaculum, maternal HCG, and the most important one, that's faster growth of cranial segment compared to the caudal segment. So gubernaculum is just a fibromuscular band that connects the testis to the scrotum, so it guides the testicular descent into the scrotum. Okay, and coming to the stages where in at which level testis is present in each period of gestation. So in eighth week of gestation, it starts descent. So in the second month, it's in the lumbar region, and in the third month, it's in the iliac fossa. In the sixth month, it's at internal inguinal ring. Seventh, it's in the inguinal canal, and eighth month, it's again in the external inguinal ring. And then ninth month, it enters the scrotum, and just before birth, it descends into the scrotum. So, just a small mnemonic to remember all of this is AP disease. So, A and P is second and third month. So, A is abdomen, that's in the lumbar region, and P is pelvis, that's in the third month, that's in iliac fossa. And then disease, DIS is for 6, 7, and 8 month, and E is for ninth month. So, at 6, 7, and 8, it's in the deep inguinal ring, that's D. I is for in the inguinal canal, and 8th is for superficial inguinal ring. And then E is ninth month, it enters the scrotum, and just before birth, it descends into the scrotum. Then it descends downwards, forwards, and medially. Alright. Then prior to gonadal differentiation, so testis lies near the kidneys in the abdomen. So there it's held loosely by two ligaments, and the cranial ligament regresses, and the caudal ligament is the one that develops into gubernaculum and guides your testis into the scrotum. Phases of descent. So transabdominal phase and inguinoscrotal phase. So transabdominal phase is when it descends from the retroperitoneum into the deep inguinal ring. And this happens due to regression of the cranial ligament due to androgens and thickening of gubernaculum due to insulin-like growth factor, and these are released by Leydig cells. And then the inguinoscrotal phase happens from the deep inguinal ring into the scrotum, and this happens under androgenic control. So coming to an important protein, so that's CGRP, so calcitonin gene-related peptide. So this is released from genitofemoral nerve, and it acts on gubernaculum and causes swelling and elongation of it. And this causes stimulation and growth. This causes stimulates growth and migration of the testis and helps it descend into the scrotum. All right, and coming to the incidence. So most commonly it's in preterm babies. So preterm babies about 30%. In full term babies it's about 3%. But two-thirds of these descend into the scrotum within 3 months. Okay, and at the age of 1 year, it's 1% incidence only. And out of these, two-thirds are palpable and one-third are not palpable. And coming to the inguinal and abdominal, inguinal is 80% and abdominal undescended testis is 20%. And usually up to 6 months we can wait, but after 6 months, the descent happening spontaneously is very rare. Coming to clinical features, there's obviously absence of testis in the scrotum, but there's normal secondary sexual characteristics. Why are there normal secondary sexual characteristics? That is because Leydig cells that are present are less sensitive to temperature and they continue to produce testosterone. So this leads to normal secondary sexual characteristics. But in on the other hand, the spermatogenesis is affected because they are more sensitive to temperature. And spermatogenesis at the age of 5 to 6 years, there is complete absence in bilateral undescended testes. All right. Okay, coming to some macroscopic and histological changes. In undescended testes, macroscopically, they are normal, but by puberty, it's usually smaller than its counterpart. And histological changes, these are important. These appear from 1 to 2 years of age. And the earliest histological change is hypoplasia of Leydig cells, and that's an important MCQ. And there are other histological changes, that's degeneration of Sertoli cells, delayed disappearance of gonocytes, and delayed appearance of adult dark spermatogonium. Coming to complications, the pneumonicus testis, there can be torsion, epididymoorchitis, there can be hernia, which can get strangulated because of patent processus vaginalis. Then there can be trauma, there can be infertility, and that's 50% in bilateral undescended testis. And there can be seminoma, which is the most common malignancy. There is increased risk of malignancy in undescended testis. And even though you do oculopexy, the risk of malignancy does not remain zero. So there's increased risk of malignancy and up to 2 to 3 times if oculopexy is done before puberty, and the risk is 5 to 6 times if oculopexy is done after puberty. And even this risk is decreased once you do oculopexy is not because of anything else, but because it's easier to identify. So even after you do oculopexy, you counsel the patient saying that there has to be regular examinations or follow up to see if there is any malignant change. And one more important point here is higher the test is, greater is the risk of malignancy. So intra-abdominal testis usually has higher risk of malignancy. Malignancy. Coming to the treatment part, so we usually wait until 6 months of age, but 6 to 12 months of corrected gestational age in if there are premature preterm babies. So 6 to 12 months is a good time, and after this, again there are complications. Coming to hormonal therapy, maybe we can use in bilateral undescended testis, but it's not routinely used due to low response rates, and there can be recurrence. Intervention, we have to see if the testis is palpable or non-palpable. If it's palpable, then we do an inguinal oculopexy. If it's not palpable, then we do an abdominal exploration. In abdominal exploration, if you find the testis, then we do a laparoscopic oculopexy. That depends on how high the testis is and if it is easy to mobilize it and bring it to the scrotum. So it depends. So we do a Fowler-Stephens operation that's most commonly done in one stage or two stage. In one stage, that we dissect the vessels and the testis and bring it down to the scrotum and do the oculopexy. In two stage, first only the vessels are dissected, then we wait for and do testicular dissection 3 to 6 months later in a two-stage oculopexy. All right, so coming back to this MCQ, let's see. So, 1 year old boy, non palpable right testis, that means it's the correct time to operate. And the ultrasound reveals the testis is located in the inguinal canal. So, we know where the location of the testis is. So, we will directly go for an open inguinal oculopexy. Thank you.